All right. Well, I think that we have a great participation right now. So why don't we go ahead and get started? Good afternoon, everyone, and welcome to EHI's webinar, 3 Strategies for Achieving Interoperability. We have a great panel of speakers today, including Andrea Darby, Assistant Vice President of OhioHealth Information Systems, Wes Rishel, who's a board member of the North Coast Health Improvement and Information Network. He's also a former VP and Distinguished Analyst from the Gartner Group, and Mark LaRoe, the Chief Executive Officer of Verato. Before we get started, I'd like to go over a few housekeeping. Could you go to the next slide, please? You'll see on your screen that we've got a chat box, and that's if you're having any technical difficulties. But when you want to ask a question, please go to the Q&A box. I know sometimes it gets confusing with the two, but please use the Q&A for your questions. And we'll let the speakers, the panelists, go through their presentations and get questions at the end. And I'd also like to just give you, next slide please, some information about eHealth Initiative. Since 2001, EHI has been convening a multi-stakeholder collaborative to conduct research, education, and advocacy. Our mission is to drive improvement in the quality, safety, and efficiency of healthcare through information and technology. Our work has been centered, and continues to be centered on our EHI 2020 roadmap to transform health. Next slide, please. And through that, we conduct research, we do education, we do webinars such as this, we convene roundtables, and we also have our EHI committees. Next slide, please. We have 4 committees: data analytics, data access and privacy, interoperability, patient and provider technology adoption. And we will be, in terms of the EHI 2020 roadmap, a lot has changed since it was first written in 2014. And we're going to be working on providing an update, and we'll be conducting some really interesting roundtable discussions at our annual meeting that's coming up in January. And it's amazing that we're already talking about 2018. So on that note, I would like to thank our supporter, Verato, for the opportunity to have this webinar. And now I'll pass the baton over to Mark LaRoe.
All right, thank you, Claudia. I appreciate it very much. I appreciate the opportunity to have the guest speakers on with this topic, this strategies for achieving interoperability. Specifically, we picked this panelist group for the audience here to give their view of this topic. The topic of the webinar obviously is interoperability, but interoperability is such a big and somewhat amorphous topic. We thought it was really important to give you 3 different perspectives on this one major problem. So we're really happy to have here Andrea Darby, with her coming from the health systems perspective, and Andrea will give you a good background of her responsibility and the successes that they have had at OhioHealth. Wes Rishel will give you the perspective of the industry analyst, as well as a major stakeholder in an HIE on the West Coast in California. So Wes is going to provide a bigger perspective to the problem of interoperability, and I'll give you my perspective on this problem of interoperability from the perspective of a technology innovator. And we think with this kind of rounded speaker base, we should give you a lot of interesting and different ideas about how to attack the problem. Now, before I introduce our first guest speaker, what I want to do is just spend 5 minutes to set up the problem a little bit, to give everybody a certain context in order to attack this discussion. And probably the best way to talk about interoperability and what it does is to talk about what it is to not have interoperability. And that's what this slide is intended to convey. In the environment of an organization, a health system, or it could be a retailer, it could be any industry, quite frankly, where there is no interoperability, the situation is such that each department, each function, each group ends up getting an application or a system to support its specific needs. And this sets up silos of systems, each one serving a different user population, each one automating a different part of the business. And ultimately, this environment, while at first being incredibly useful and pleasing everybody at the onset, because business processes are being automated that hitherto were entirely manual, this ultimately leads to excessive manual effort, as people need to bridge the gap between the systems that aren't interoperable. People need to create spreadsheets and bring them to the next cubicle. I'll refer to that later as sneaker net. But more importantly, from a business standpoint, this introduces inefficiencies and, in the worst case, errors, and ultimately provides an inability to measure or improve the environment because the systems aren't speaking to one another and nobody's got a holistic view of the operation of the business. And now in healthcare, this problem is even more poignant. In healthcare, this same topic of interoperability goes beyond errors and inefficiencies and bears very specifically on certain strategic initiatives that are front and center in the health system in the US today. Specifically, interoperability is absolutely essential for hospitals to be able to merge together and to combine their systems and combine their patients. It's essential to measure risk or report compliance. It's important and essential to coordinate care both within the four walls of a health system and also to other health systems, to CMS, to payers, to departments of health. Everybody is part of this larger ecosystem of care, and interoperability is absolutely at the center of it. Managing population health, connecting with customers, customers meet patients, managing patients, and maybe even most importantly, or not the least important at least, is the ability to incorporate new innovative applications. I believe we're on the cusp of all sorts of new innovative applications for physician assistance, population, precision medicine, translational medicine, and expert systems that are going to make the delivery of care much better than it is today, but if we've got an environment that can accept that kind of innovation. So this is what interoperability is all about, and so the problem at hand is how do we go from an environment where what you see on the left, disparate systems with their disparate databases, overlapping data, how do we get that disparate environment to behave more like a single cohesive system running the entire business with one version of the truth, one database? So how do we get that? That's what interoperability is all about. And the road to interoperability is not a one-step process. This is rife in the history of IT. Every industry has gone through this process where the start of interoperability is really manual. It's people walking from cubicle to cubicle and creating spreadsheets and delivering them to colleagues to transfer data. But the first important technical level of interoperability is integration, taking one system and integrating it with another, A to B, and then B to C, and then C to D, and then A to D, then C to B, and then D to A. What happens with integration on a point-to-point basis is at first it's a very good idea, but at scale it begins to break down as a spider web of point-to-point integrations take place, which then ultimately gives way to the better idea, which is to consolidate. As the software matures, more and more of the functionality to run a business, in our case, to run hospital systems and other healthcare systems, can be consolidated because it's become standardized, and that's the advent of the big EMR and EHR packages that we know today. And this is the all-in-one strategy where all the functionality is integrated because it's delivered from one single vendor that builds it as an integrated whole. And then the final step in the evolution of interoperability is the full mix and match environment where you don't have to buy all the products from one single vendor, but you have sufficient robustness of standards and the availability of APIs such that you can interconnect best of breed componentry in a complete mix and match mode. Now, there's no one single path through this life cycle. It kind of looks very linear here, but what you're going to see before the end of this webinar, I think you'll understand that it's not a one answer fits everybody, and nor is it a single linear path through this process, unlike this diagram here would imply. And in fact, I'll just do two more slides and I'll turn the podium over to Andrea, but bear with me and let me put forward to you what I believe is the basic landscape of interoperability that we're facing in healthcare. And I call it the Consolidate, Integrate, and Innovate landscape. The first most obvious strategy in order to integrate or have systems become interoperable is to consolidate as much as possible within a single system. And in fact, this is going on throughout healthcare as you see health systems standardize upon one of the big EMR packages. And this is a great strategy. In fact, 10 years ago, this could have been the end of the interoperability problem. If you can get all the functionality we get today in one package, and we had none of the new requirements that have cropped up over the last 10 years, this could be the end of the strategy. But what happens is almost every health system is faced with not just one major EMR, but through mergers or acquisitions, perhaps two major EMRs, both of which might have cost $50 million or $100 million to implement. So nobody's going to throw them away, which leads us to the strategy of integrating. So you consolidate first, and then you integrate where you must across major concentration points of functionality. And this too might seem like the end of the problem. If you got, one or two major EMR systems and I integrate them in a relatively contained way, won't I solve the problem? And what I would say is, I don't think the problem is solved yet, because I think what we are all going to be faced with, whether it's front and center in your IT plans today or not, is there's going to be a whole portfolio of new innovative applications. Things that are being delivered by the entrepreneurial vendors out there who are thinking of the next frontier of healthcare and bringing functionality to bear. These are the last things to get ultimately integrated into large EMR packages, because the EMR packages, the whole value about them is integration, not innovation. So this is really the landscape that we're talking about, and the strategy that it implies is that health systems ought to think about consolidating the core standardized transactions that run the business. So registration, scheduling, billing, those kinds of things that are relatively standard and codifiable without much innovation ought to be consolidated and can usefully be consolidated. But everybody needs to be prepared to accommodate a layer of best of breed applications to inject all of the new things into the health systems and to interoperate with things outside of the four walls. And my final slide before I turn over to Andrea is finally just this one. What I believe is necessary in order to bring all of this together is not just consolidation, not just integration, but a backplane of interoperability that is API based, so it's easily connected to. It's based upon standards, and clearly I'm talking about HL7 and FHIR and the profiles from EHI. But also, importantly, this backplane includes common services, things like data storage, analytics, and even identity, which will be my topic at the end of today, but services that provide a backplane for all of the other systems to use. So not just standards, but even services. And one of Verato's partners refers to this backplane idea as the healthcare operating system. I think that's a pretty apt characterization of it. We all need an operating system on which to inject or in which to put all these systems. Well, with this as a landscape, if you will, and the introduction of a few terms like consolidation, integration, and innovation, let me now get to the main part of our presentation, and let me introduce Andrea Darby from OhioHealth to give all of us her experiences from the real world of integrating and interoperating within OhioHealth. Andrea?
Thank you. Next slide, please. I wanted to give you a brief introduction to myself and to OhioHealth, just so you have a framework of reference. I'm the System Vice President for IT, and I'm responsible for all of our applications, both clinical and revenue cycle across the system, our interface and interoperability teams, as well as a lot of our imaging and biomedical equipment. So kind of have the entire footprint of what we're talking about wanting to address through interoperability. OhioHealth is a large system. We're 11 hospitals in Ohio, covering approximately right around half of the counties in the state of Ohio. We have over 250 physician practice locations and 600 employed providers. We have a large affiliated network. We have several hospitals that we have clinical arrangements with or assisted managing. We do have our own OhioHealth group, which is a team that's dedicated to our own self-insured population, which we refer to as our Ohio Healthy population. And we manage that through our clinically integrated network to roll out our population health programs. We do have OhioHealth Physician Group, as I mentioned, which is our employed providers. And lastly, we have health and wellness services that we work with local employers, and we are working on continuing to look at expanding our employer footprint with go-to-market offerings of bundles of services we can provide to our employers, as well as on-site clinics in several of their locations. So the next slide, please. So let me tell you a little bit about our journey to interoperability. You know, kind of as it's already been kind of talked about so far, we began our journey, let's just say in 2012, when we were getting ready to sit down and try and figure out how to get 3 of our largest vendors to talk together better, and then figure out from there how to address our smaller vendors. At that point, our major vendor for our clinical operations in our hospitals announced that they would be, in essence, sunsetting the product we were on, and gave us an opportunity to step back and look at this is the perfect time to look at developing a strategy to move to a single enterprise platform. We chose Epic in late 2012 and began our implementation in 2013. So even though I told you right now we have 11 hospitals, I will tell you that even we have not been able to kind of fully get there. We only have 7 of our 11 currently on the Epic EMR, but it was the basis for our strategy. And so when we went to go kick this off in 2013, we learned that while we thought we had maybe 5 or 6 EMRs that we were going to need to integrate together into a consolidated enterprise system, we actually had 17 different EMRs that we consolidated into a single master patient index. And that was key for us in order to really start that journey of ensuring we could connect our patients appropriately and provide the right level of care throughout our system. We began our implementation in our go-lives in the summer of 2014 and finished late in 2015. So at this point, minus the 4 hospitals I mentioned and a few of our newer practices, we are largely all on Epic, as well as our home care operations. But we continue to bring in new practices that we acquire, and how do we bring their data over? So we're always looking to address the question of how do we consolidate that clinical information into our record. And we're continuing to look at what is that infrastructure we need to overcome these barriers. What's going to make it easier for us? And so we're always evaluating what are our identity solutions, and do we need to be making additional investments? We have standardized our change management process. This has helped us get our new practices and systems on board in a reasonably straightforward and easy fashion. Next slide, please. So we've made great progress, but there's still a lot of challenges that are out there. Even with all the work we've done, we're still running probably somewhere between a 5 and 6% duplicate rate for our patient population. Some of this still comes from human error. Some of it comes from continuing to add in new source data as we acquire practices. Another challenge for us is, depending upon which institution you're at, we have between 30 and 70% of the physicians at that institution who are independent, but credentialed and working at those hospitals, and are in disparate EMRs at their own practices. So this is part of our clinically integrated network strategy, is how do we connect to them in a way that moves the key clinical data back and forth appropriately and easily. With our payers, we're looking at what's that focus on, where we're at with bundled payments, the quality measures, working with a lot of our different payers on quality metrics, quality measures. How do we get that data? How do we pull that data in from our clinically integrated network practices? And so it's really, how do we get that right information on the right patient to our payers in an easy fashion? I mean, in pure candor, we have a few payers that still like to get paper documents, and we're driving hard to move them away from that and to leverage our EMR access in order to minimize the need to do that, and exchange relevant data beyond just the strictly, I sent you my claims, but the clinical data that allows them to see the documentation that supports those claims. And that ultimately helps our organization get better information into our quality metrics and prevent denials. We also continue to have some challenges with other providers. Many of our practices that are in our clinically integrated network are smaller. They're on more what I would refer to as smaller mom and pop type EMRs. and those are hard to connect to, as well as they are not active in any type of HIE within the state. So it's just difficult to exchange that more complex information with them. Next slide, please. So we've taken a four-pronged approach for how we want to address interoperability with our existing facilities that we're still working to migrate over to our enterprise platform, as well as our independent providers who are in our clinically integrated network. We strongly leverage Care Everywhere. This allows us to connect easily to other Epic sites in the state of Ohio and across the nation. We are a robust user of Care Everywhere and have exchanged in the past 6 months well over 3 million documents back and forth between other systems. So it's a key strategy for us to enable us to provide the correct clinical information to our providers and our clinicians as they're providing care for our patients. We're also a member of Care Quality. Care Quality is through the ONC and the Sequoia Project, and this enables us to connect to non-Epic EMRs that are in the Care Quality network. So we're connecting here to examples are eClinicalWorks, Athena, NextGen. We also connect with the eHealth Exchange, and we do some robust connections through that with the VA. Our next method is our statewide HIE, which is OHIP, which is the Ohio Health Information Partnership, also called CliniSync in the state of Ohio. And this enables us to exchange CCDA documentation with other EMR and sites in the system within the OHIP system. It includes the majority of all the hospitals. I think almost all of them are now in our HIE for the state, as well as a large number of our independent physicians. And then lastly, we will do some data exchange via direct connection. It's not our preferred methodology, but we will do that in order to ensure that we are able to exchange the appropriate clinical data that's needed. Next slide. So as you can see, we're taking active steps towards our interoperability. We really want to make sure that as we're acquiring new facilities, as we're looking at other hospitals that we will be having affiliations and agreements with, how can we make that upfront investment to ensure that there's the appropriate capital available and an opportunity. This is key for it was key for our strategy and key for many other organizations and health systems is to take that time to make that investment. There are a lot more tools out there now than there were, just 3 or 4 years ago, and leveraging those tools to provide an increased interoperability is really the strategy that we're taking and encourage others to take in that interoperability journey. We continue to make and encourage others to make incremental investments through the longer term change. I mean, there's smaller incremental pieces we can continue to do. We continue to look at our disparate systems in our organization and our partners. How can we move them onto a more common platform or an easier to connect to platform? We are really prioritizing our interoperability initiatives ahead of some of our other initiatives to enable us to continue to move forward with that strategy. There is a little bit of wait and see that's out there. I know we work with a lot of groups that are not as aggressive as we are in terms of the progress they want to make with their EMR. And that's been a little challenging because we're fighting against their wait and see type methodology. We recognize that there are physician provider offices that just don't have the capital to invest in these new systems. And so I think that's part of the struggle that we and others in the industry see is how do we connect to those providers that are still key to our strategy, but just don't have the resources necessary to make that change. Next slide. So, really to what was talked about at the beginning, we're really looking for what are those things that are going to continue to make us more fully interoperable. Better patient matching, as I mentioned earlier, it's a key strategy for us. We continue to look at tools that are out there to say, what can we do to improve that match, to lead to more of an identity proofing type solution. We know we need to have that clean data and to have a meaningful exchange. We as well use the standard FHIR and HL7 for our data exchange. We're working with the API development so that we can connect to the newer, more innovative EMRs and vendors that are out there, providing some unique services that we're just not able to offer right now, but we don't want to miss out on those opportunities. So it's a lot of time for us to be invested in that, but we know that's where the future is, and we want to be on the front edge of that curve to achieve full interoperability.
Okay, Andrea, thank you. This is Mark Leroux again. Thank you very much for that. Everybody, I'm sure that people are thinking of questions they have for Andrea, and I just want to remind everybody that they can submit questions online, and then we're going to try and reserve time at the end of the presentation so that we can go through these questions. But Andrea, thank you very much again for that presentation. Now, the next speaker I'd like to introduce to you is Wes Rishel, and as already mentioned, Wes is a board member for an HIE in California, and he has that perspective. But equally important, and the reason why we asked him to participate, is that he's got a long historical perspective of the evolution of technology within healthcare. And with that brief introduction, Wes, do you want to go ahead?
Thank you, Mark. Can you bring up the next slide, please? So I need to explain retired health IT nerd. When I retired from Gartner, I tried, first thing I did was alphabetize the spices in the closet, and then I tried basket weaving and digital photography, and I found that the activity that got me out of the lazy boy easiest was actually doing the stuff I did back when I was a programmer. So I have gone back to the North Coast Health Improving Information Network, not only as a board member, but as a volunteer programmer working directly on the projects that we're doing. Mark's slides and Andrea's history really gave me an opportunity to look back over the course of my career. In 1984, I joined a company called Symborg Systems. I was employee number 2. And our goal was to do that first level of integration that Mark described within a hospital. That is to say, to connect the departmental systems with the nursing unit, and while leaving the departmental systems in place. What we found is that the first problem hospitals had to solve in 1984 was getting on a single number for the patient within the departments of the hospitals. The buzzword of the day was the unit number, meaning one number across the hospital. One of the systems we developed early was a master patient index based on Bayesian probability, which was a master's thesis for a student of my mentor, Don Symborg. And we found that with that system, we could get to a common identity within the hospital. The Bayesian techniques have continued to be the basis for probabilistic identity matching even to today. So some things change the same, some things stay the same for a long time. Some of the successes and issues we found with the early MPI systems was first dealing with regionally specific populations. In San Francisco, there's a number of people with last name Eng, spelled E-N-G, N-G, Chins, Chans, and Chens, etc. And the logic necessary to match misspellings was an important part of the Bayesian approach. The biggest challenge we found was training the registration clerks to enter a full name for an accurate search. What we found is they tended to want to put in a few letters, find the first thing that might be a match and choose that and go forward. We actually developed a quality system reporting on how well the clerks did their matching, and we generated rooms full of paper that never got looked at. The other challenge we had back then was the reluctance of registration vendors to integrate. Looking forward to the work I'm doing with NCHIN now, I would say that problems worthy of attack prove their worth by fighting back. We're still dealing with many of those same issues today. In fact, it's remarkable how the technology can work and progress can still remain elusive. Next slide, please. So where I retired to was Humboldt County, up in the upper left corner of California state, a large expanse with a small population, and many of the problems that we associate with healthcare today. We have a high poverty rate, we have an opioid death rate that's twice the state average, and every state is having problems in there. And sort of on the slide there, there's some statistics that show that compared to the rest of California, we have a long way to go, and this is not unusual for rural populations to develop the best quality of life for the people in our quality. Next slide, please. Look, as has been reinforced in my going back to work in the trenches, as it were, is that the number one real-world interoperability challenge is the opposite of the old joke we used to make as programmers. We used to say, garbage in, garbage out. If users make mistakes, the program doesn't work. What the real issue is garbage out, garbage in. That is, the data that gets put into the system before sharing with other systems is just good enough for that application. So if I can collect just a nominal amount of registration data and then find a match or decide to create a new record, and that gets the bills paid, that gets the data to the health insurer, and we get paid, then that's what comes out across the network. Next slide, please. In the rare case, or the unusual case, where we need to collect more data in order to get paid, or some other very high economic priority, then the people operating the system are willing to go back and collect more data, and more data then becomes available to everyone else on the network. Next slide, please. In looking at the challenges in Humboldt County, we're working to address the same issues that Andrea described and that everyone else described, which is to say that we need to improve the patient experience of care, including both quality and satisfaction, improving the health of populations, and reducing the per capita cost of healthcare. And I don't think anything brings to home more the issue of the per capita cost than the current political debates we're having about healthcare. Warren Buffett was interviewed yesterday, and he made the point that healthcare is such an expense now relative to our gross domestic product that it impacts our ability to be competitive in the world. What's clear is that the cost of healthcare, I think we'll go to the next slide now. The cost of healthcare really is focused on not evenly across the population. In fact, there's a term, the frequent flyers, that's often used. If you look at the annual costs of the nation occurs in healthcare. 20% of that comes from only 1% of the population, and 80% comes from only 20% of the population. So part of the focus of NHIN, as well as many other places, is focusing on those frequent flyers, or the more politically correct term, familiar faces. Next slide, please. If you look at those, and one way to do it is a study that was done about 10 years ago, based on the looking at the contributions to premature death. Why do people die when they die earlier than the average person for their population and circumstance? Only 10% of that is due to healthcare. Another 30% is due to genetics. The rest of the cause of premature death, and of course, the couple of years before death is the period where people typically expend the most healthcare resources. The majority of the contributions come from environmental exposure, patient behavior, or their social circumstances. Next slide, please. So our goal at NHIN has been to sort of take the view of integration that Andrea and Mark described, which is, well, I think Mark focused largely on consolidating a large, complex enterprise. Andrea began to focus on going beyond the enterprise to other healthcare providers. And I'd like to present a view, which is that thinking only of the healthcare providers in creating solutions to the frequent flyer problem leaves us short of a great deal to say about the opportunities we have to improve care. So what we really need is coordination, not only on ED visits and hospital stays and care in the clinic, but among the clinicians and the mental health providers that come out of a stream of healthcare that's quite differently funded and operated than most clinical care. Nutritional assistance, various county-operated assistance programs. The VA, we have tribal organizations in our area, and we have a number of non-governmental assistance programs. And finally, we've been doing some work with law enforcement on recognizing situations that start out as law enforcement calls that should be dealt with in terms of substance abuse or mental health or a homeless issue, thus getting to the social causes of frequent use of the healthcare system. Next slide, please. What we found in going down this path is that those interoperability problems of silos that were described within the framework of healthcare entities exist even more strongly when you go outside of that framework. In fact, Humboldt County, which is not that unique as a county, has a number of different IT systems, each of which was created through a different funding mechanism in legislation. And they typically don't talk to each other within the county, much less with outside systems. So our challenge in trying to coordinate the care is to create case management and care coordination for the familiar faces subpopulations, people that are often the hardest to track. Next slide, please. We look at the challenge as creating timely sharing of events across domains. That is, if somebody's coming to the ED and has a case manager in a government program, let the case manager know. Has a referral with a local non-government organization that's providing housing, let the appropriate person know. And similar kinds of arrests, school incidents, things like that. And needless to say, the biggest problem is identity mapping. In other words, the issues that I was addressing in 1984 are just as relevant today as they were back then. We need to not only map people across IT systems, but over time and over drastic changes in their circumstances. People who are now homeless, for example, weren't always that way. People who were relying on tribal healthcare system for care may have moved into a different constraint and so forth. So in moving on so that Mark can complete his talk, I just want to go to the next slide. And as a nerd, I can't help but love Buzz Lightyear's slogan, "To the universe and beyond." Your nerd gets to speculate on, well, what is there beyond the universe? I would say that to 1984 and beyond is where I am. And what we're looking at in identity mapping is two options. One, continue the Bayesian approach, get good enough patient identity information and probabilistic matching, or try to find a way to find a source, a curated source of a national database of people and map the information we have about a patient onto that national database. Thanks a lot, Mark.
All right, thank you, Wes. Thanks very much. And everybody, thank you so far for hanging with us. I've got one more important bit of information to convey to you, and this is my perspective. And I think you probably believe I already gave you my perspective earlier in the presentation, but I want to take a particularly pointed look at the issue of interoperability, and specifically identity interoperability. And what do I mean by that? Let me go right to what I mean by that. So HIMSS has given us a framework for interoperability. They describe 3 different levels: foundational, structural, and the semantic level. Each of those levels is intended to answer some critical questions that allow systems to talk to one another. For the lowest level, can we connect to one another? At the structural level, can we talk to one another if we're able to connect? Do we understand the same language? And the semantic level, can we understand what each party is saying? Can our systems interpret the data that's being conveyed for some useful purpose? And what I propose to all of you, and even to HIMSS, is to think that indeed there's actually a 4th layer of interoperability that we all must need to address now, and that is, are we talking about the same person? Right? So none of the lower level ones matter anything unless we're talking about the correct person between systems. And that's the final thing that I'm going to talk about in my presentation. And I know the idea of identity interoperability, it's a new phrase, and so maybe people don't have a foundation to understand it. Let me build up that foundation with just one slide, this one, to say the reason that identity interoperability is so difficult is because identity data is prone to so many errors. You know, what tags a medical record, or what tags a patient walking in the door, or a patient on the phone, is not a password, it's not their DNA, it's certainly not a national medical ID number, but rather it's their name, their address, their birth date, their gender, their social security number, their phone, or their email, or some combination of those things. And the problem with all of those things is that they either go stale with time, or they get entered with ambiguity because every name isn't structured the same way, or there simply are errors in the data entry process. And all of this adds up to what is very now widely believed to be a fundamental state of identity data, and that is that upwards of 30% of all identity information that is in databases today, whether it's healthcare or governmental or even retail, 30% of all identity information stored in databases is either incorrect or out of date. And that's the genesis of all of these interoperability problems, and the duplicate rate that Andrea mentioned earlier that she's experiencing at OhioHealth, no matter despite the heroic efforts that her teams put together to drive it down to the 5 and 6% rates. So we need to solve this problem, and we probably need to solve this problem in an interoperable way, something that solves it not just for one system, but for all systems, because that's the whole intent of interoperability. And so the question I'm addressing here in the final few slides of the presentation is, what would an identity resolution service look like? One that could serve this diverse landscape of systems that's inevitably going to crop up in health systems of the future, and even of present. And the first thing that would come to mind is, well, this is precisely the role that the Enterprise Master Patient Index, the EMPI, was designed to solve. It was designed to solve this problem. It has interfaces, well-described interfaces. It's intended to absorb identities from all of the contributing systems, make sense of them, and create a golden record. The problem with EMPI technology is that it can't solve this problem at scale. The problem really is that EMPIs, their performance gets worse and worse the more systems that contribute to them. The errors from any one system end up contributing and compounding within the EMPI, not scrubbing themselves out. Add to that the fact that too much time is required in setting up the EMPI and tuning it. In fact, the tuning is often system specific. So every new system that's brought on might imply a different tuning set that conflicts with the previously onboarded systems. And then ultimately, these EMPIs, their performance, their correctness in matching depends too much on the data quality. And in an environment where you have not one EMR, but multiple EMRs, not one innovative system, but multiple innovative systems, not just inside the four walls, but interconnecting with external data, there's no possibility of setting up governance standards in the data world to propagate data corrections out to all of the contributing systems. The whole concept of EMPI, what makes it work, begins to fall apart, such that the EMPIs are not nimble enough to accommodate new systems, they're not scalable enough to accommodate the many systems, and ultimately they're not accurate enough because these errors accumulate. So the question is, what can we put in place that is better than the EMPI, and why can't we expect the EMPI vendors simply to make their products better? This slide, in just 15 seconds, is meant to convey to you that we're at a state today with probabilistic matching, Bayesian matching, as Wes mentioned earlier, that we've pretty much achieved everything that it's theoretically capable of delivering. All of the MPI innovation that we've experienced starting in the 1990s and through the early parts of the 2000s with the major EMPI vendors or MPI vendors have been to get better matching and better matching up until where we are now today in 2017. We're pretty much at the asymptote of this curve. There's not much more to improve upon that with respect to matching. And so that leads us to the question, well then, if we can't improve the algorithms any further, what is the solution? And what I'd like to propose to everybody on this phone is that this next generation of problem, this new era that we're moving into, is going to require next generation technologies to solve it. And this combination of technologies I've coined universal MPI, and you'll see why that is in a little bit, but what we're talking about is a new architecture for MPIs that combines big data, first and foremost, a new kind of matching algorithm called referential matching that depends upon machine learning. It gets smarter and smarter the more it's used. And it's cloud-based so that organizations can implement with API simplicity, as this slide says. So the idea here is to build a very large reference database, a nationwide database of demographics for all possible patients, invent and implement a new matching algorithm that's more accurate and doesn't require tuning for every new source, and implement it in a way that people can simply plug into it rather than deploy it. And so I'm going to spend a couple of slides talking about this concept and how it can be made real and how it can be integrated within existing environments. I've spent one slide just talking about this reference database because it is so important and it's such a key to the overall solution. The thing that makes this entire idea work is to have a reference database comprised of, that has a nationwide scope, but most importantly, it's comprised of data sources that are not healthcare. I listed up here an example of data sources that are as comprehensive that they provide a nationwide coverage, but are orthogonal or distinctly different from healthcare, so that they don't contain the same errors and omissions that typical healthcare systems suffer. So credit systems or telephone company white pages, interactions with the government or legal systems, these three major sources can encapsulate most of the identities across the US through different avenues of collection. And the idea here is to curate billions of records from these multiple sources and build a comprehensive database and put that database together, not just by putting all of the data in the same database, but put it together very carefully through explicit data science, such that errors do get scrubbed out and that identity profiles become cumulative and correct rather than cumulative and incorrect. And to do so at a scale that no single healthcare system could ever afford to do on its own. In fact, no organization could afford to do this on their own, but it could be done one time on behalf of many organizations. And ultimately, what you'd end up with is a reference database that has hundreds of millions of identities, that has dozens of years of historical data, so that it doesn't matter whether a healthcare record was captured 20 years ago, it can still be matched to an identity today, even if that person has moved twice and changed their name once in the process. And maybe most importantly, but somewhat understated here on this slide in the lower right corner, this database would also receive millions of updates to its demographic data every month to make sure that it had the latest information about everybody, and that information could be made available for the matching processes. And the question is, how would that work in a real MPI environment? And so I drew a simplified diagram here that will basically describe it, but in essence, what would happen here is that all of these systems would communicate with not a real on-premise MPI, but a virtual MPI in the cloud. And it would communicate with that MPI through APIs, as I mentioned earlier, that are HIPAA certified and high trust secured. But most importantly, it wouldn't end here. In fact, if it did end here, this would be no better than a probabilistic MPI that's available from many different vendors today. What's most important is that virtual MPI would be linked and validated by all of the identity information within the reference database. And this arrow that I just built on your slide set is the most important thing on this entire slide, because what it does is it brings in all of the data science and all of the data that's been put into the reference database, and it uses that to correct, straighten out, amplify the patient data that's in the virtual MPI. And so what we're talking about here is an environment that's much more accurate, requiring no tuning, and is very fast to implement. As it says here, just plug in. But perhaps the thing that's least recognized in this diagram, and because it's not drawn here explicitly, but I'll do it in the next slide build, is that this reference database is receiving millions of updates per month, tens of millions of updates per month. And those updates flow not just to the reference database, but they ripple all the way down to the virtual MPI, so that it's continually being refined and corrected, even if a patient isn't presenting themselves with new data at the front door. It's being updated through external processes that are brought to you through this process. It's a very, very powerful concept. And now the final concept on this overall slide that this architecture I want to convey is that it's not an all or nothing strategy. In fact, probably the most important information I want to convey to you is that you can use this universal MPI idea even if you currently have an eMPI, even if you spent a lot of money and years of effort to implement an eMPI supporting, your current needs for identity resolution. You can use the universal MPI service to make your current MPI work better. You can use it to correct the mistakes that the MPI makes. You can use it to find the matches that the MPI cannot find of its own accord. And you can use the universal MPI to accommodate the new needs that are too cumbersome to plug into the eMPI. It takes too much effort and too much time. So you can put in place the universal MPI as an adjunct to minimally disrupt your current operations with your MPI. And it's this mix and match capability which truly makes this idea powerful, because it makes it possible to deploy it without a complete rip and replace. Now, the final slide in my sequence is this one, and I put this up here not because it's front and center with most people's minds of a problem they need to solve, but in the environment whereby a hospital system is using this universal MPI service for its virtual MPI, and perhaps a public health department is and a payer is, each one of those is building a virtual MPI within this cloud environment. But because each one of those virtual MPIs has all of their patients linked to the universal reference database, they then can be linked to each other, or one of them can refer to common patients with the other with unequivocal, without any ambiguity, meaning there can be no mistake because they've been pre-linked together to the same universal reference. And this opens the door to a much broader mechanism for sharing information between entities. This is Wes Rishel's main point, that we need to enable this, and this process, this infrastructure has the inherent capability of supporting that. So let me summarize the main messages that we've tried to convey to you, and then I'll open up the phone for the last negative 2 minutes. I know we're 2 minutes over. I'm looking at my director here. Let me just summarize. Andrea Darby told us through her experience at OhioHealth that regardless of the path you choose to achieve interoperability, she recommends that you should be taking active steps today. If it's incremental, so be it. Start incrementally doing it. If you have the wherewithal to make the large-scale investments and move today in a large consolidation, it's valuable to do. Either way, you should be moving today and not waiting. I believe Wes's main message is that the real health requires interoperability that goes well beyond the healthcare institution and is inclusive of an entire ecosystem of providers and participants. And my message to you is that full interoperability is essential, and it can be achieved even today, but it requires new technology, this universal MPI technology that I've described. Now, with that, I do want to thank everybody. We are over the hour, and we were a little bit late starting and then maybe a little bit mistimed in our presentations, but we've got a handful of questions that have come in. We don't really have time to distribute them, and I don't want to impose upon people, but I do thank you for participating. If you want to learn more about Verado, then certainly come visit our website. There are two main things that we do for customers, and that is to offer our universal MPI as a primary MPI solution, but even just as important, we are able to turbocharge your existing MPI, make it better, operate better through automated data stewardship or duplicate resolution. And with that, let me thank you all. I appreciate your time, and I look forward to talking to you sometime soon in the future. Thanks very much.
And Mark, this is Claudia. I'd like to thank you and the support of Verado for this educational webinar. It was really, really wonderful. The panelists were terrific. For the attendees, we can follow up with you with the questions that you've asked. So on that note, I'll sign off and end the webinar. So thank you again, everyone.